streaming? Gotcha. But there's people out there right now all over the place. Another 30 seconds or so, or how you feeling? Please do that now. I gotta start. Okay? Yeah. Well, for now. Do I have mic? Am I live? Okay. Good morning, everybody. and welcome to the first, and as I say, inaugural Staff Sergeant Fox Suicide Prevention Forum at the beautiful state capitol here in Georgia. I want to thank everybody for being here regarding such an important issue, one over the decades really that have been looked past. And I'm happy to know that the VA today sees suicide prevention as their #1 clinical priority, as it should be. We have today an amazing group of experts, but as most programs, we're going to go ahead and start with an invocation. And the people who are giving the invocation is David and Brenda Fox. They are the parents of Staff Sergeant Parker Fox. They have turned their tragedy into an amazing story to make sure other families don't have to suffer what they've had to suffer over the last couple of years. And before I introduce them, I want to tell you, and I'm going to actually read directly how I first had a communication with David Fox. When I was preparing for this, I thought, I don't know enough about Parker, and I wanted to make sure I reached out to his family to see if this is something they could be a part of going forward. And I found David on Facebook. I had this long email prepared about what mission of this forum intent is, and how we expected to move forward. And I decided, well, I'm not going to send him this long email. So on June 28th at 11:03 p.m., I sent him an instant message. This is a man that knows nothing about me, not what my intent is, absolutely nothing. And I said, hey, David, my name is Sean Hanley. I'm a Marine veteran from Georgia. Do you have a few minutes to talk? That's all I said. That was sent at 11:03 p.m. At 11:05 p.m., sure, Sean, I'm always here for our vets. Talked to David about this exchange, and clearly he thought I was in trouble. He thought I was a veteran in trouble. 2 minutes after 11 o'clock at night, he responds because he's willing to take the loss they have in their family to another level of making sure other veterans and other military don't have that same suffering. So it's going to be an impactful morning. We have amazing people here, but with that, I want to introduce Mr. David Fox and his wife, Brenda Fox, the parents of Parker.
Thank y'all so much for inviting us to be here today. We are honored to be a part of today. But right now, if you will bow your heads with me, let's pray. Heavenly Father, we come before you today, humbled by the love you have for us. We come to you with grateful hearts for the many blessings you've given us. And we come before you to ask for your wisdom to guide us. We pray that our efforts help others, and we pray that those same efforts glorify you. We pray that you fill our hearts and souls and minds with love and understanding, and that love and understanding guide us in all we think and say and do. We ask these things in the name of your Son, Jesus Christ. Amen.
And David is just going to give us opening remarks about Parker.
First, I'd like to thank you for inviting us here to be with you today. We appreciate the legislators and the leaders who formed this grant program. and also the organizations that are turning it into results. So let me tell you a little bit about the person whose name is on this print. Brenda and I know that there are thousands of other people whose stories unfortunately end the same. And those stories are just as precious. You've seen some biopics and maybe some information on Parker. Most of those are army photos. As a proud parent, I'll just say he looks like a superhero. I'm going to say it. For example, if you've not seen, there's a sniper ghillie wash photo of him dripping in mud. It's pretty impressive. That was taken just a month before he died. There was even talk of using it as a publicity photo for the sniper program. As a child, Parker loved playing superheroes from the beginning. He always wore a blanket, like a cape, around the house as he played. He even insisted that his new baby brother receive a cape immediately when he came home from the hospital. And he did. Right there in the living room when we walked in the door, he got his cape. And we took a photo to document the moment. Parker was extremely small growing up. But he was never bullied at school because he always had loyal friends who would step up to defend him. In high school, he joined the wrestling team. He added muscle onto that lean frame. With that new confidence, he naturally started to develop a guardian role himself, a hero, but one with a big heart. In the morning, Parker was having breakfast at McDonald's. He had grown a beard with large, long sideburns. He was lean and muscular from wrestling. A young boy saw him, walked over to Parker, and whispered, "Are you Wolverine?" Parker said, "Yeah." The kid said, "Can I see your claws?" "Sorry, man. I can't do that here. It might scare people." "I get it." That was Parker. It really was. He was self-reliant. He never wanted to be a burden. As a teenager, once he had his first job, traveling and stopped at a convenience store for snacks, he would always insist on buying his own. Like his siblings, they were happy to let mom and dad pay for it. Parker continued those traits as a young adult, first as a lifeguard, then joining the military, choosing infantry from the start, and finally as a sniper instructor. But that self-reliance worked against him as he began to struggle internally. It made him reluctant to seek help. But he was always there for his friends. Several approached us after his death with the same story. Parker was the one they had called at 3 a.m. when they were in a bad mental state. Parker would go and sit with them until morning, helping them get through that night. One of those stories had happened just a week before he died. This young man cried as he told his story. Parker hid all that. His buddies had no idea of his struggle. More than once, Parker spoke to us of other soldiers who had died by suicide. We could tell that those losses were hard on him. We asked if he was having any trouble. "No, I'm fine. I'm fine." He said, "I have good and bad days like everybody else." That seemed like the natural response you would expect from your child. But he wasn't fine. We later learned that he didn't want to try internal military counseling. He was afraid it would end his career. So he started seeing a counselor outside of the military. COVID stopped those sessions. It stopped his work. It closed the gym. Those were his primary coping outlets. He secretly spiraled downward without any of us realizing it. On that last night, alcohol distorted his thinking. You can hear it in the tone of his notes. He felt that his mental state was becoming a burden to those around him. And as I said earlier, Parker never wanted to be a burden. So as a parent, My mind tries to think of all the ways we could have intervened and helped him before he made that irreversible choice on that night. Maybe a diagnosis of what was going on, better access to counseling, a therapy dog, restricting his gun access, the buddy check system, and there's many, many more. It just shows you how complicated this can be. Parker's is just one story, and the contributing factors in every one are unique. That's why we need a variety of services to identify and address issues earlier, with different approaches catered to each unique case. We've got to surround our heroes and pause or stop them before they can make that choice that can't be undone. Thank you.
Thank you, Brenda and David. I now want to ask Rachel Holstick to come and lead us in the pledge this morning, please.
Allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you, everybody. Being a enlisted Marine, I'm on this side, and all the doctors are over there. So, and they're not that kind of doctor, trust me. But we have an amazing group of subject matter experts from the Department of Veteran Affairs, from DOD. We have our commissioner here, and a little later we're going to have Congressman Bishop and Congressman Austin Scott join us in a tele manner. So with that, I'm going to go down the list here and have each of our panelists go ahead and introduce themselves. I want to first ask Dr. Sundarama to please introduce yourself. And when I talked to her last night for a few minutes, she shortened her own name for me. She clearly got the Cliff Notes. I was an enlisted Marine. Please introduce yourself and tell us about your mission at DOD, and then we'll have a brief introduction with each of you.
I'm Sundarama, and I did not shorten my name. That is, I just don't pronounce an extra set of R's. I'm a public health physician by background, and I have been in the field of suicide prevention for about 25 years. Started off at the state of Massachusetts and then worked for the National Suicide Prevention Resource Center, which is a substance abuse and mental health services administration funded center. After that, I worked for the Congressional Research Service for a little bit. And then since 2010, I've been working on military and veteran suicide prevention issues. I'm currently the Deputy Director of the Defense Suicide Prevention Office and honored to be here.
Okay. Thank you. Commissioner, why don't you go ahead?
Sure. I'm Commissioner Trish Ross from the Georgia Department of Veterans Service. So we do a few things when it comes to suicide prevention here within the state of Georgia. So we are the lead for the Governor's Challenge. We also have our suicide prevention and outreach coordinator, who I want to introduce, Ms. Calandra Ferguson. Fergie, if you'd stand up. And so we are working across the state with a variety of partners, both at the federal, state, and community level, to help get in front of suicide, to be proactive instead of reactive. I'm a 25-year Air Force veteran, having served in this position going on almost 2 years now, and this is definitely a priority for us in the state of Georgia and us as a department. Thank you.
Thank you. Dr. Moore?
Thank you. Hello, my name is Brian Moore. I'm a health psychologist by training. I'm a professor at Kennesaw State University, and I'm the director of the only military health research unit in the University System of Georgia. So we work very closely with GDVS on suicide prevention programming, outreach, and then helping to identify areas of hotspot to help direct resources across the state. We also work with the Department of Public Health's Injury Prevention Program on the state's comprehensive suicide prevention plan. And so a lot of this comes from my 13 years experience as an Army infantryman, and then also a fair amount of my team is in the back there, and then their collective experiences as enlisted Marine back there, Coast Guard research experience, and then military family member experience. Thank you.
Thank you. And Dr. Burnett is with us from the VA, and I'd just like to comment, both Dr. Sundarama and Dr. Burnett made the trip from Washington to be with us just for a few hours today, and they're headed right back. And Dr. Sundarama missed her 13-year-old's birthday yesterday. That's the dedication these people have. So Dr. Burnett is also the real subject matter expert when it comes to the Staff Sergeant Fox grant. Doctor?
Thank you. Todd Burnett, Senior Consultant for Operations with Suicide Prevention Program in VA. Clinical psychologist by background. Started out doing direct service provision for veterans at our medical centers, then overseeing regional services across the VA, and now national services for suicide prevention. Our office oversees VA policy. Of course, it has the Staff Sergeant and Parker Gordon Fox grants. We have the Governor's Challenge, annual report, and everything else that touches VA, including our partnerships with DOD and other federal agencies around suicide prevention. It's a pleasure to be here with y'all today.
Go ahead.
Okay. Good morning. I'm Rachel Holloman. I am the Director of Suicide Prevention and Federal Grants for the Georgia Department of Behavioral Health and Developmental Disabilities. And so we partner with GDVS for the Governor's Challenge, as well as other veterans initiatives, and DVHCD is also launching some additional initiatives in regards to not only our veterans and their families, but our active men and women in service and their families.
Great, thank you. I want to start, I do want to recognize a couple of folks. Rick White, thank you for being here today. Dr. Brown, Steve Mendez, one of our board members at the Georgia Department of Veteran Services, and all of the people representing the department and all of your veteran service organizations. Thank you for being here. I want to kind of get right into the idea of how we're going to move with this forum. Open mic for all the experts as they will jump in, because a lot of times what works in one region of the country might not work in another. So I'm happy that we have some real local expertise here, that we talk about the southern or the southeast Georgia. But I want to talk first, touch base with Dr. Sundarama, and we're going to pull your deck up right now from DOD. And we talked a little bit on the phone and just to kind of set the table. The doctor's been involved with this for 25 years. She is the #2 over at DOD in regards to suicide prevention. And I made a special note that when we spoke, we would talk about what the Foxes went through and the concerns of military personnel fearing for their career, and how going to get help within the chain of command that could hurt that. And I don't know if you want to start with there, and then we can go through your whole deck. So thank you.
I have something about that in my deck, so
Sure.
if I can address that as we go through.
Do you want to bring that mic a little closer to you? I think.
I can do that. And how do I advance the slides?
Okay, I'm sorry, your slide.
Oh, he's
He's going to do that for you.
We can go next.
Okay, go ahead.
Good morning, and I'll just start with a little bit of data. The Defense Suicide Prevention Office puts forth an annual report on suicide, and we should have our 22 data coming out towards the end of the month, but this is based on 21 data. We have approximately 519 service members who die by suicide every year. Of those, 328 are active duty, 74 reserve, and 117 in the Guard. Most of the service members who die are young. They're enlisted males, 20 to 24 years old. And most of the method, the most common method is firearms. I'm sure none of this is a surprise. None of these data are a surprise for anyone, but this is kind of consistently what we see year after year, and this is what goes into informing any of our prevention efforts. Next slide. We also look at family member data. Our family member data is delayed by a year because we have to rely on the civilian data collection systems to be able to report on this. So we're looking at about 202 family members who died by suicide in calendar year 2020. 133 spouses, 69 dependents. Still, the most common method is firearm. But if you know background about suicide, the most common method across the United States is firearms. It tends to be more in the military population than in the civilian population. We're looking at about 70% deaths by firearm in the military, whereas it's closer to 50% in the civilian world. All right, next slide. So the way we look at it is really kind of looking at the idea that suicide prevention cannot be one thing. It's there has to be a combination of initiatives, a combination of protective factors that help address the issue, not only way before the thought of suicide comes into someone's head, but also the idea that it's not just an individual, but that the fact that an individual is part of a community, a part of a larger society, and there are risk factors at all these levels that we need to look at. And while some initiatives may resonate for some people, there are others that are needed for other people. So starting with the individual level, there are biological factors. If someone has a mental health issue, that needs treatment. So that's at an individual level. Relationship issues, that's one of the commonest risk factors we see in the military, where there has been a relationship issue and that leads to further risk factors and other complications that eventually lead to suicide. Community settings, which are the social relationships, whether the access to care, whether you're able to find care, whether you feel comfortable seeking care, all that is part of that the community level risk factors. And finally, broad societal factors. I mean, the availability of firearms that a person who may be suicidal can easily access. All the other societal level risk factors that go into a person's mental wellness are part of that issue. And so, as you can see, it's not just a crisis line. It's not just, having good treatment. It's a whole lot of issues that go into being effectively able to prevent suicides. Next slide. And so what we follow what is called the public health approach, and these 7 strategies that you see in that circle around there is something that the Centers for Disease Control, which is I guess around the corner for you guys, has put forth as evidence-informed practices for suicide prevention. And so we look at really trying to address each of these elements of the 7 strategies as part of our approach to suicide prevention, and recognizing that less than half of the people who die by suicide really have a diagnosed mental illness. So if we just go after treatment, we're not going to be able to effectively prevent suicide. And then those are some other data points there, which I will not read out to you, but we can go to the next slide. So just to kind of give an idea of where the Defense Suicide Prevention Office sits, we're in the Office of the Secretary of Defense. But we're not in any of the military services. So we provide oversight and policy guidance and technical assistance to all the services and their suicide prevention programs, but we do not have direct control over those programs. Those are handled at the service level. So our role is more of taking what is known to work in the larger world, adapt it for the military setting, do pilot studies, make sure that these programs are adapted for the military and for specific services in the military even, and then provide that to the services for them to implement. So our role is more of that technical assistance role, making sure that they are able to evaluate, the services are able to evaluate their programs for effectiveness, helping them with funding to do that. And also the data collection, the whole overarching data collection surveillance system is part of our function. So that's kind of just to give an idea of what we do. Next slide. So if I could like classify what we do into four categories, the first one is fostering a supporting environment. And we have what is called a dedicated prevention workforce, recognizing that suicide does rarely occur by itself. There are generally other issues that are going on in that person's life. And so how can we work integrated across all the prevention fields so that someone who is suicidal is getting that service no matter which door they come from? And then reducing the risk through service member wellness. The Secretary of Defense released a memo called Taking Care of Our Service Members and Families, and that kind of drives a lot of our initiatives and provides the basis for why we're doing this and how we should do this. We're also doing on-site installation evaluations. So we are actually there at selected installations across the world, looking at the programs and hearing from service members what the actual issues are and how we could better shape the program so that they are served better. Lethal means safety. As I said, firearms are the most common method of suicide. And so providing that space between, the time and space between when an individual decides to end their life and having access to that firearm could be critical in saving a person's life. So we emphasize safe storage so that, even that time between going and accessing their firearm gives that person some time to think through whether they really do want to, access that firearm or there's something else that they could rather do. So we have a number of initiatives that promote safe storage, and through messaging, through the different, we work closely with the VA, with the other nonprofits and other firearm groups across the country to promote the messaging, because naturally nobody wants to hear from, the Department of Defense, but they would much rather hear from a firearm retailer or a peer or someone else that they trust with that messaging. Counseling on access to lethal means. This is a training that we have for providers, so that when they do see someone who is at risk for suicide, they're comfortable having that conversation about safe storage. And then the next part is addressing the stigma and barrier to help seeking. I'll get a little bit more into that, but we are looking at that issue about stigma, about help seeking, and how best to address that. And how do we also do that? Who is the messenger? So that's a big part of where that stigma comes from. For some people, hearing from a two-star general who said, "I sought help and my career was not affected," that may be effective for some people. For some others, it is their peer who said who's promoting help seeking. For others, it's their master sergeant. So it has to be someone that actually resonates with that person, so that promotes the help seeking. The other part of that is making sure we have these services when a person seeks help, so that there isn't that waiting period between when someone is actually willing to seek help and when they can actually see someone. So addressing that issue is also critical, and we're looking at that. We're looking at stigmatizing language in DoD policy. So part of we're actually doing an entire policy review of all the forms, all the documents across the department to look if there are languages which should not say commit suicide. It should, when it's talking about seeking mental health, it is doing that in a constructive, in a way that promotes help seeking rather than stigmatizes it. So that's another effort that we're doing. And then education and availability and benefits. And that's just going back to the messaging about what is out there and how can people seek help, whether they choose to seek help in the TRICARE system, in the military mental health system, or outside. And then the clinical services, of course, that's part of, that's core. If there are people who need mental health services, making sure that there is evidence-based treatment for them. There's a screening for risk in all the primary care clinics. So those are two initiatives that we're doing from the clinical side of the world. Next slide. And then, if you haven't already heard about the SPRC, that is, this is the Suicide Prevention and Response Independent Review Committee. So last year, there was Congress directed the Department of Defense to set up this independent review committee to do a thorough review of everything, all the risk factors in the military for suicide, and come up with recommendations. So earlier this year, the committee completed their findings and provided there are about 127 recommendations that they put forth. And right now, and last week, just on last Thursday, the Secretary of Defense signed a memo directing actions stemming from that report. So we are all now in the process of creating plans and actions and milestones to make sure that those recommendations are implemented. You can find that report online if you'd like. I would say the major takeaway from that is really to look at quality of life and how can we improve the quality of life of our service members as well as their families, and looking at that as prevention and really going way left of like addressing a suicidal behavior. Of course, you need to address someone who has suicidal behavior, but how can we get it to that point that that person does not feel like their life is not worth living, or how do we make sure that they feel their life is worth living? Next slide. That's just an overall mission of the Defense Suicide Prevention Office, and I think that's in your brochures. I will not go into much of that. Our vision is to someday get to a suicide-free military community. Next slide. This is just a path that the Defense Suicide Prevention has gone through. We were established in 2011, again, as a result of a congressional report that looked at all these different services having their own suicide prevention efforts, but no central coordinating body, no one to really do that translation to practice. So there was a need for a central office that was able to drive suicide prevention for the military. That's why we were established in 2011. Since then, we have published a number of policies and also created the Defense Strategy for Suicide Prevention, which is modeled on the National Strategy for Suicide Prevention. We're currently in the process. The national strategy is getting revised, and the Department of Defense is at the table as part of those revisions. And once we have a new national strategy, we will be having action plans and a revised defense strategy for suicide prevention that will reflect the national priorities. And of course, we have the annual report and the SPERC implementation. So next step, next slide. And in terms of our comprehensive approach, the way we are organized, we have 5 pillars. One of them is looking at governance and policy, so making sure that policies we put forth are effective. Strategic integration and reporting, that's our surveillance work. Research translation, I spoke with you about, so taking findings that are known to work in the civilian world and adapting that to the military. Partnerships and engagement. A large part of how we do our work is through our collaborations. We are just a staff of 18 people, so we don't necessarily can do everything. So we work with organizations such as this. We work with states, we work with other federal agencies, making sure we can amplify their messaging, their efforts, while they can also amplify our work. So a lot of our work happens through that partnership, and that's where Todd's office and mine work really closely together. And integrated primary prevention goes back to that, making sure that there is not just suicide in this door and then substance use in this door and domestic violence through another door. They're actually integrated services. When someone goes through one door, they have access to the other services as well. Next slide. So these are just, I'll have just 2 slides, one on stigma reduction. And this is, I already spoke about the policy review that we're doing. This is an infographic that we put out, and if anyone of you have been through the security clearance system, the SF-86 is a form that you fill out, and it has a section there asking about your mental health, mental illness, whether you're seeking treatment. So this was an infographic, and that is a concern because when people are seeking security clearance and they have to report on whether they're seeking mental health treatment, they now go with the belief that if I do put down a yes here, I may be denied a security clearance. So this is looking at an infographic that says that is not actually the case. There are very few instances, and it's generally not related to that mental illness that would cause a security clearance to be revoked because, so this is actually an infographic that we put forth to educate about that SF-86 form. Similarly, we're looking at we are promoting other messages for help seeking. What we find is also a generational difference when we are looking at the current generation of like 18-year-olds and 19-year-olds. They have grown up with a much more they've grown up with a therapist, they've grown up with a life coach, so they are much more willing to go to a chaplain or go to someone who is willing to be that coach for them without necessarily seeing that as mental illness. However, as the population, as we're looking at a slightly older population, even those who are closer to their 30s right now, there is that stigma that we still need to work against. We do the outreach events and, of course, promoting access to care in every way we can. Next slide. And then finally, just the service member to veteran transition. And this is where, this is not the Defense Suicide Prevention Office, but we work very closely with the Transition Assistance Office or the Transition Assistance Program. And part of that is making sure that service members are receiving the care they need as they're getting handed off to the VA. Of course, it's their choice whether they choose to enroll for VA benefits and whether they choose to go to for VA care, but making sure that they are aware of what resources are out there as they make that transition. And anyone who is currently seeking care in the military health system, we have what is called an in transition or a warm handoff, so that they're connected with a provider in the VA system before they leave the military. Of course, the separation health assessment and the warm handovers. I think that's about all I have.
Okay, thank you, Doctor. And obviously, with that last slide, the transition over to veterans makes sense. And thank you for touching on the stigma reduction issue. I think that's pretty significant. You know, when I transitioned out of the Marine Corps back into civilian life, I had a pretty good plan that seemed to work out okay with me. But there's that big gap when you have your brothers and sisters that you're with every day in the military, and you're so close to them. And one day you're fighting for your country, and the next day you have your discharge papers. And that's the moment when a lot of these now veterans, 24 hours of being a veteran, their family might have moved from where they were. They might have lost relatives, and they don't have a good home to stay. So with that, I want to pivot over to Dr. Burnett. I know you're going to touch on the transition effect and the importance of helping those veterans. But Dr. Burnett, as I said earlier, is also the expert on the Staff Sergeant Fox grant. After you speak for a few minutes, Commissioner and Dr. Moore, please jump in about how the Fox grant seems to be working on a local level. But Dr. Burnett, thank you for being here.
Thank you all for having me. And it's always a pleasure to hear Ramya speak, all the great things that they're doing at DOD. I have the pleasure of working with her very frequently. So in case you're wondering, do all these federal agencies have a unified plan for addressing suicide? And we do. So the White House has released what's called the White House or the National Strategy for Reducing Military and Veteran Suicide, which is the strategic plan for the nation. And included in that, if you've not read that, are charges to the federal agencies for working collaboratively to establish a unified national strategy for reducing suicide, which includes work with the states and local agencies. So I get to work with Ramya on that, everything she's doing on the DOD side, and of course, that pivotal point in transition from service and what that means when someone's coming out. We know that that's an at-risk period for veterans, especially in that first year. There's a ton of transition that happens, not just collectively in your community, but personally, how you look at yourself and what your role and contributions are. So there's unique factors that are drivers of risk that we want to focus on there. I'm going to level set the conversation kind of nationally. Do we have the slides?
Sure.
Doug, are we able to pull those up? So I want to give you a big picture and then narrow that down. I'm going to reiterate some of what Ramya talked about and kind of highlight some key points that I want to be sure you take away. I don't know what all of y'all's understanding is, what level of understanding you have about the different services and the different programs we have. So I'm going to touch on some of those. And I've seen several of you all pulling up phones and taking pictures. Please pull them back out, because I'm going to have QR codes up here so that you guys can connect to some resources that I want to be sure you can help us amplify, that you get out there as far and as wide as we can. So to give you a context for this conversation, if you don't follow it as closely as we do, 30,000, about 30,000 or 87 U.S. adults per day died by suicide. Anyone want to guess what year that was? That was 2005. Just 15 years later, we jumped from about 30,000 to 45,000 by 2020. And the 2021 reports from CDC, that's jumped to 46. And then we're looking at around 48,000 U.S. adults died by suicide. We're talking about 130 a day. That doesn't count the almost 12.4 million adults that reported having serious thoughts about suicide, those who got admitted and weren't fatal, millions and millions of people. And so what that means, if you don't follow this really closely, is that in any group we talk about on this panel, every member on this panel, every one of you and everybody who's watching on streaming, suicide is always personal. My Parker is my brother. I'm sure you have a face, a name, someone, your family, friend, someone you served with, a neighbor, a work colleague, someone you went to school with who comes to mind when we have this conversation. It's always personal. So there's been no other name other than the names of my two sons and the name of my brother that I say more than Parker's. I talk about him every day because he represents, and what we're doing here represents who your Parker is. So let's talk a little bit about what we're doing and why we're doing it. You can go to the next slide here. Thank you. So when you look at the three core tenets that serve as the basis for everything we are doing in VA, there are three basic principles that we believe in 100%. You can see them listed here. The ones that most people aren't very familiar with is that middle one when we talk about a public health approach, which is instead of a medical model for how do we solve depression, how do we solve substance use disorders, how do we solve those things, this looks much more broadly to how do we partner around things like policy, upstream risk factors, how do we do engagement beyond just mental health and kind of clinical issues, because it's going to take everybody partnering together to make a dent in this. No one's going to accomplish this alone. Not the VA, not DOD, not any other agency, not yours alone. We've got to work together. That third one here, everyone has a role to play. I think everyone agrees with that, but they're not sure what that role is. And so I want to help point to some directions of some things we've got going on. And then I want to invite feedback from you all on anything we're missing to help us see the way. So I'm going to talk a little bit about Mission Daybreak. I'm going to talk a little bit about our governors and state challenges, which will set them up. Let's talk about what's going on here in Georgia. And of course, I'm going to talk about our grants program here. So if I said 130 per day, that comes out to about 17 veterans out of that 137. And of those 17 veterans, 7 will have used VA services. The majority haven't. So that means where are those veterans going? They're going to you all. They're going into the community. You're going to see them locally at someone who is not within the VA. And so we have got to talk about how we're all working together to understand the drivers or the unique drivers of veteran risk. I used to see patients who used to have private practice in the community. And I can tell you after being in the VA for 15 years, I was not equipped on that end for the unique circumstances, the unique language, the unique culture of veterans. We've got to be sure we can understand that to have credibility. Otherwise, they won't come or stay with you for that. And so I'm going to give you some resources here as well on training about military culture and some other things here. If you're not aware, these things are completely free. I don't know that most people know about them, but I want to get them out there to you. All right, you can go to the next slide. Oh, stay here. Go back to that one for a second. I think the one that makes most people most uncomfortable, if we're being honest, is that first one. If you're a clinician, most clinicians are uncomfortable with that first one. Suicide is preventable, because I can tell you as a family member, forget being a clinician. I can tell you as a member of someone who died, a family member of someone who died by suicide, we did and would have continued to do everything we possibly could do to make that not happen. So when you tell me suicide is preventable, part of me goes, but I can't stop someone from doing what they're going to do. I can't stop someone if they don't tell me. That's not what we mean by suicide is preventable. You're right. I can't stop someone from doing something they're determined to do, but I can address the drivers that cause people to do this. And they're not always what you think. We talk a lot about mental health, but that's not the sole driver of risk for people. When we talk about food insecurity, housing, employment issues, family and marital issues, those can also be drivers of risk. Pain, insomnia, things that you won't necessarily see in a mental health clinic, but nevertheless will drive someone towards risk. Those are things we've also got to be talking about. All right. I'm not going to do it to you again, Doug. You can go to the next slide. All right. So there's the number, just like Ramya. They're getting ready to release their annual report here in a couple of weeks. So are we. So our current information is through 2020, 6,146 veterans. I want to be careful about the number because it gets a lot of attention. Anything greater than 1 is a problem. I don't care if that number is a little higher than that, actually, or a little lower than that. No one's patting themselves on the back for anything more than 1, right? And so that's too many. When you look at the big picture and the number per day, so if we said 130 per day and 17 of those are veterans and 7 of those will be veterans that come to VA, doesn't matter. What you want to understand is veterans are about 57 to 60% higher risk than the non-veteran population. And I want to spell out for you exactly why that is and what we need to be looking for. All right, you can go to the next one, Doug. So are there some unique drivers of risk for veterans? Absolutely there are. And you can't think a veteran is just like any non-veteran. There are some things that are similar that you see in the non-veteran population, and there are unique things. So veterans we know have higher comorbid rates. That means they have multiple health factors that are typically going on with them. And those health factors are things like pain, insomnia. Often they'll have legal issues. Frequently, that'll be the case. Food insecurity or housing can be a problem, especially following the period after transition from service. Employment issues can often be a real challenge for veterans. And then there are things like insomnia, TBI, mild traumatic brain injury. These are things that we know represent higher risk in the population that are represented at higher ratios among veterans. So we've got to pay attention to these things. Of course, if substance use rates are higher, employment issues are unstable. If you've lost a sense of community, family issues often follow with that. And we know when you get isolated, your risk goes up. That's specifically true for veterans in that period of transition. When we talk about loss of community, I can't tell you how important community in the military community is for veterans, a place where they understand a common language and are with people who they don't have to explain things to. And so that loss of community can be disorienting for people. Lower income or lower employment. So we want to talk about if you go to our website, you'll see things like financial resources, and you'll see some of our grants in the Staff Sergeant Parker Gordon Fox grants. You'll see some of our grantees. A lot of them are doing financial aid and assistance. And you'll go, well, what does that have to do? That's exactly why, because we're not wanting to reach just people who are in crisis. We're wanting to reach people before they get to crisis, which means we have to do things like legal aid. We have to do things like justice involvement, keeping people out of jails, things like employment issues and financial services. Those are prevention. We know that if we intervene at any point in the process, you can change the trajectory of risk. So for someone whose driver of risk is pain, then supporting treatments for early intervention in pain and coping is a suicide prevention strategy. Insomnia issues, those are suicide prevention strategies, not just mental health. So you can see these. You go to the next slide. Let me give you a context for how we frequently talk about suicide, and we rightly so. So for VHA user veterans, 58% of them have a mental health or substance use disorder diagnosis. But I want you to look closely at this slide. And just think for a second, is there anything here that jumps out to you in terms of the greatest risk for suicide. If you were to look at national coverage on veterans, you would think that PTSD is the greatest predictor of risk. It is not. It is not. And not every veteran has PTSD, and people who have PTSD or depression are not necessarily going to be on a trajectory to be suicidal. The biggest drivers are substance use disorders. Impaired judgment at the time of distress leads to a shorter window of response. So my tolerance, if I have a lethal means available to me and my judgment is impaired, that's a circumstance that was true from what you guys said, Parker. That was true for my brother, Dwight, and that is true for many veterans that I see. So when we talk about lethal means safety, many people get confused when we say, well, why are you guys talking about lethal means safety? Because that is, especially for veterans, if we can create time and space between a crisis and access to that lethal means where you get in touch with someone, we know we can save lives. We know we can save lives. 90% of people who have an initial attempt do not go on to make a subsequent attempt. So if you can intervene that one time, you are likely saving a life and a family going forward. So let's go to the next slide here. Ramya touched on this a couple of times in her slides, but I want to show you exactly what that difference looks like between veterans and non-veterans for both men and women. Y'all pay attention to that says that part that shows firearms there, especially. Doug, can you click one more time? Because I think I highlighted it. No, I didn't. Go back. Thank you. All right. So if you look at that, it says veteran men in 2020, 72% of veteran males who die by suicide used a firearm. If you look at the non-veteran men, that's 55%. So we're talking, what, a 17% difference? I think what's most telling is that number right next to it. U.S. adults in general, the use of firearms is going down. It's good news because survivability rates are less than 10%. In many studies, it's less than 5%. You don't get a second chance with a firearm. If you look at all other forms of suicide combined, about 5% are lethal. For firearms, it's about 90 to 95%. What do veterans feel most comfortable with and equipped to manage? Are firearms. It's not about firearm rights. It's not about that. It's about secure storage, which police and soldiers and everyone else understand. It's about secure storage, especially in the moment of crisis. And there's a lot we can do to increase secure storage and lethal means safety before we get to a moment of crisis. And so you will see a lot of our campaigns that are focused on lethal means storage are about having discussions in advance of those in crisis moments.
Dr. Burnett?
Yep.
Can I interrupt you just real quick? We have two members of Congress that are going to come on staggered a little bit. So if you could take a little pause now and jump back in a few minutes, that would be great.
Absolutely.
I can barely hear.
Great, thank you. So we're going to pick up with Dr. Burnett in a few minutes. I want to introduce Congressman Austin Scott. Apparently something happened in Washington over the last week, so they weren't able to be here and they had to quickly get up to DC, and I think they are adjourned for a short time. Congressman Scott, I actually had a long conversation with him this morning on the ride in. A fierce advocate for veterans and Georgia military, with all of our military installations and so forth here from the 8th District. Sits on the House Armed Services Committee, which is crucial when it comes to our active duty military and how they are dealing with suicide prevention. So with that, Congressman, thank you for being here, sir.
Hey, Sean, thank you for having us. I can barely hear you, but I do want to first thank David and Brenda Fox. You know, their son has done tremendous things. His legacy lives on through the work that they're doing with this foundation. Where with what they're doing in his legacy, we're doing the right thing. I believe the right way. And what I want you to know is that there is a tremendous amount of research out there that has been done on combat-related stress and soldier-related stress. Dave Grossman is one of those that's done a tremendous amount of work. I think one of the things that's unique about this program as we push forward is that we're doing it in the way of grants. And if you talk to our veterans that have seen combat's bad enough when you just see it in pictures, but the people that have actually lived it face to face, more oftentimes than not, they actually need someone to talk to about it. And when I've gotten to have a conversation with many of these warriors, their comment is, "Well, I'm scared that if I tell somebody the truth, then my file will be marked, and all of a sudden I'll be seen as not a warrior anymore." When their feelings are totally natural, and they're concerned about actions that agencies may take with regard to um, firearms and other things that they have. And so what this legacy of Staff Sergeant Fox, the beauty of this is we're doing the right thing the right way, because we're giving these grants to organizations that I believe that our warriors, our combat veterans, are going to be very willing to speak with, and be able to work through some of the issues that, candidly, if you don't have them, it's not human to not feel those emotions after you've been through these things. So we've got a great person, and I call her Colonel, but you call her Commissioner, and Patricia Ross there as the head of the VA in Georgia. And so great team here that's been put together. There's a great legacy here that's going to help a lot of people. And I'm sorry that I couldn't be there in person. My wife actually didn't know if I was going to be in Georgia or DC until last night, and I didn't either. And I know my colleague Sanford Bishop's going to be on the phone with you in a little while. You'll find bipartisan support for this program and the work that's being done here. And so, Sean, thank you so much for what you're doing. Uh, you know, to the parents of Staff Sergeant Fox, thank you so much for continuing to press forward this and not laying down, so that your son's legacy and your work will help other people hopefully not have to endure the pain that I know that you have felt as the parents of one of our warriors. I can't, Sean, if you're there, I can't hear anything. Hey, Sean, I can't hear you.
Veterans of all the states in the country and the fifth most active military, or did I get that backwards? We're now eighth. Okay, we're moving up. That tells you a lot about Georgia. Okay, Dr. Burnett, we might have one more interruption with Congressman Sanford Bishop. Please pick up where you left off.
That was a perfect segue.
Okay, great.
Well, let's go to the next slide here. Let's talk about the grants themselves. So if you are not as familiar with the national program, there are three grantees for Staff Sergeant Parker Gordon Fox Suicide Prevention grants out of the 80 that we have nationally. So if you read this from the left, this is a pilot program. So Congress funded 3 years. So these are 1 year renewable grants. So we are given $52.5 million to award, up to $750,000 in single award grant ceilings. If you do that math, 750 times 80 grants, you're going to get $60 million when we have $52.5 million. Not all grantees request the full amount for that. Depends on what the scope of services is that they're asking. We have prioritized awards that are focused on specific at-risk veteran populations. So within the veteran population, we know that there are specific populations that are even at higher risk for this. And those are transitioning veterans, 18 to 34-year-old women veterans under the age of 35, LGBTQ veterans, a number of minority veteran populations such as American Indian, Alaska Native, Asian American, Hawaiian Native, and Pacific Islander, and a number of others. Geographically remote veterans, male veterans over the age of 55, and that list goes on. And so we have prioritized grants that focus in those areas where access to services or engagement is limited, because we want to get people connected to whomever they can get connected to. If those are community partners, if those are peer agencies, that's who we prioritize for that. Services that they get in these grants. So mental health screening for suicide risk is what is required to be a participant in this. They get education about suicide risk and prevention. They get access to resources for that. There is the provision of emergency care services, and I'm going to tell you in just a second here the impact that that's made. So these grants were announced in September a year ago. They had 6 months to stand up their programs and launch them. Services were required to be launched by January. Some were able to ramp up very quickly and began sooner than that, but all of them were having some services available through their grants as of January. So we had essentially a half year of those all going full bore. Last year we had 80 grantees across 43 states, 4 territories last year, and Washington, D.C. We didn't have Guam because Guam didn't submit a proposal. That took them a little bit more time. I do want to note that 21 of those grantees were tribal nations who has a very high risk subpopulation. So those were Navajo, Choctaw, Cherokee, and then Alaska Native tribes, which we were very glad to see. Just 2 weeks ago, we announced the new awards for this year. 77 of those were continuing from the first year. 3 are new grantees. So that includes now 43 states we're covering, all 5 territories. So Guam is on board, and Washington, D.C. We are already preparing the notice of funding opportunity, which we will release earlier this year. There's a long process that goes into getting that ready, but we will get that announced earlier this year to allow more time for sites to submit for those, and hopefully announce those earlier in the summer if we can get it through the clearance process. Here's what's important: impact just for essentially half a year from January on. So we had more than just around 16,000 veterans. So these grants are open to both veterans and active duty and their families, because the biggest way you're going to keep a veteran engaged in care is to care for their family as well. The family is often going to be the first one to see the signs and symptoms. I always love having families in when I still see patients. So when I'm treating, I love having the wife or family member there, because they'll call out underreporting. So they'll say, "Oh, no, that's not true. You need to tell them this," which is great. So about 16,000 veterans engaged. The majority of those who've been engaged are right where we want them to be. Those are in rural and highly rural area, which is a big population here in Georgia. And they are high-risk veteran subpopulations. So we're getting more women veterans, we're getting more minority veterans, we're getting more of the populations that we know are at high risk, that 18 to 34-year-old population. About 6,000 referrals came out of that. 300 were identified at being at an imminent risk at the time when they came in for services. I consider those lives saved. Those people who had the courage to come in somewhere, even if it wasn't VA or CBOC or something, they came in somewhere, they they took that step, that incredibly harrowing but courage-filled first step to speak it, what they were worried about saying to someone, and they got help. That's wonderful. That's why we're doing this, to save those lives. About 2,300 non-emergency referrals. A large portion of those go to the community. About half of those, maybe a little bit more, get connected to VA care if they're able to see them quickly. They will take them to care if they want to receive it. If they don't want to receive care in the VA or they prefer to be referred to community, they're tied directly to the community for that. And then about 3,200 social service referrals. So you can see on the right here the 3 grantees we have for Georgia. So with Georgia Department of State, Highland Rivers Community Service Board, and Northwest Florida. If you want to see all the grantees, we list them publicly. If you guys want to see what services they offer, I put on the bottom left there complementary services. And so these aren't just traditional clinical services. If you look at some of the services they're offering on tribal lands, for example, it's wonderful to see that they're using culturally relevant. So you'll see talking circles or healing sweat lodges. You'll see some of those services offered there, a lot of peer support services. It's wonderful and it's innovative and it meets veterans at the point of need. You can go to the next slide there. Some other things I'll touch lightly on. So our Governor's Challenge, I think you mentioned in the introduction, you guys are familiar with the Governor's Challenge. If y'all aren't as familiar with that, so these are partnerships between VA and SAMHSA to work with states to develop statewide and local plans. We do have some funding that we're going to be distributing. I think it's $10 million this year, and I think it's each of the next 3 years that we will be providing funding to help states conduct suicide mortality review committees so that they understand exactly the drivers of veteran risk in those states. And then we can strategize actions and plans to convert that into actions or specific deliverables. You can go to the next slide. What's awesome about that, by the way, is there are 1,500 current partnerships that we have across the U.S. That's amazing, y'all. 1,500 partnerships that we have with community collaborations across the U.S. and territories, all focused on one goal, which is reducing and ending veteran suicide. Mission Daybreak, don't know if y'all heard about this. This was a $20 million innovations grand challenge. So basically it was a call to the U.S. public outside of federal service agencies to come up with their best solutions to help us think of what else can be done to reduce and end veteran suicide. We had about 1,300 submissions for that. We had 30 finalists. And then we had 10 that got final awards for that. We are partnering with some of those agencies now, or some of those apps. There were 3 charges that we had for that. One was to what can be done to increase lethal means safety, what can be done to maximize the use of artificial intelligence to identify people who are escalating towards risk, and then third, what can be done to increase access and engagement in services, including things like peer services. And so we have a lot of things that we're following up there. But please don't stop the good ideas coming. If Georgia has some wonderful ideas that that we need to be aware of, please let us know.
Doctor,
Always open there. You have something?
I just wanted you to elaborate on that. I mean, when I saw the Mission Daybreak and the details, it was fascinatingly innovated by the VA. So I give you all credit to look towards the private sector on how to, end veteran suicide, military suicide. Since there are 10 awardees, can you discuss 1 or 2 of them and some innovative kind of new thoughts from the private sector?
Sure. So I'll tell you about 2 or 3 of them. So Reflex AI is one of the ones that uses AI technologies to train first responders. So how do you train someone? For those of you who are mental health clinicians, how do you train someone to be prepared to answer a call for someone who's in crisis? Generally, your academic training doesn't necessarily equip you for that. And so having some AI solutions that really help someone know how to listen, how to engage, and how to help save a life in that moment is wonderfully innovative and will help take us not only in the veteran crisis line, which we manage from our department in VA, and SAMHSA's 988 management of the same things, but to the community and first responders out there. Now there is Project HOZO, which is Televata. And this is an app that is focused on integrated treatment plans for American Indian, Alaska Native veterans that incorporates into their treatment plans culturally relevant items for them. Things like healing and talking circles, peer support networks. So if I'm a geographically remote veteran that lives on a reservation and I don't have many other veterans near me, to have a sense of community, that app helps connect like veterans, wherever they may be, into developed community. There are a number of these. There's Stop Soldier Suicide, which is looking at AI solutions to look at social media predictors of risk to identify people who are escalating, and there are a number of others. I can go on and on. If you ever want to see the whole list, I can give you a link. It's on our site. You can see the ones who are winners, and I think we have contracts with 5. You don't have to be a winner in that to be working with us. So we're looking still to the community for new and innovative ideas out there.
Since there are so many submissions, do you see this being an annual event or?
We have other things like it. So this was unique in that we had $20 million for that call to action, but we have multiple contracts that we continue to do all the time. And so if you have good solutions out there or ideas, something innovative that we need to be aware of, you'd like to throw our way, please let us know.
Great. Thank you, Doctor. So I'm going to call on our commissioner, Commissioner Ross, if you'd like to kind of touch base on the, how all of these efforts by the DOD and VA kind of come together on a local level that you have to deal with every day. And I'm going to leave it to you to reach out to Rachel and Dr. Moore to kind of include in your conversation on the local level.
Okay, thank you for that. So we basically are the boots on the ground here in Georgia. We have been fortunate to be a recipient of the Staff Sergeant Fox grant, both the first year and now for the second year, and have been able to do a tremendous amount here across the 159 counties in the state of Georgia. Some of the highlights, we partner, we've screened over 4,000 individuals with our partners here with Dr. Moore and the AIMS Center. That has been at not only outreach events across the state, partnering with the Guard here in Georgia, but also with all of our offices. We're fortunate that we have 55 offices that help veterans get their earned benefits through the VA, and we all have screeners there. I remember a 2-week period where I think we had 5 confirmed saves, and I'm looking at folks here in the audience as part of our team who helped save those individuals, where somebody came back and said, by engaging with you, talking to you, getting to the right resources, I chose to not take my life. So we are doing that here within the state. We're also part of the Governor's Challenge, and I know Rachel can jump on with more of this, but that's partnering with more than 60 organizations across the state, to include our churches, veteran service organizations, of which we have some of our partners here present, to create this network where, again, we are trying to get ahead of somebody having suicidal ideations, where we're trying to train across the state, what are those risk and protective factors? Ms. Ferguson has gone not only to our own team here within Georgia, but to external teams. Any group that actually asked her to speak, she did a big training this past weekend on not only how to identify those factors, but how to ask the question. So coming from a military background myself, being a casualty officer, again, at the worst part in anybody's life, you have to be able to talk about this. That is first and foremost. If you can't talk to somebody and ask them straight away if they're thinking of killing themselves, how can you have those deeper conversations and get them connected, whether you're the right resource and they need somebody to just understand and to talk to because you've been through some similar things, or whether you have to reach out to our partners, both within the VA and then our community-based organizations. We've also been very fortunate the state of Georgia actually awarded through us a mental health grant for our military members, veterans, and their families to the tune of $750,000 this last year. And we're looking forward to hopefully the state will allocate additional funds in coming years. But this was able to grow a complete clinical team with the Cohen Veterans Network, which, even though it's based in Hinesville outside of Fort Stewart, our largest installation of our 9 here in the state of Georgia, they do telehealth and can reach anybody throughout the state. Additionally, we were able to partner with Emory University and get another outreach person so that they can go to our active duty military installations, get those folks prior to transition, and if they have post-traumatic stress, traumatic brain injuries, can come at no cost here within Georgia. And that actually is a national program where anybody can come here in Atlanta to their program. And so, again, trying to be that boots on the ground, getting ahead of suicide and preventing suicide, not only within our veteran population, but our active duty members and our families. And I have to tell you, we've got tremendous partners, not only here in the audience, but up here on the panel with me. So I'd like to first turn it over to Dr. Brian Moore. They are definitely our biggest partner, our main partner with the Staff Sergeant Fox Suicide Prevention Grant. And I'd like for him to talk about kind of what his team is doing for the state of Georgia, how they are partnering with us, and then, of course, what he's seeing, because he is an expert researcher and as well as in this field. Dr. Moore?
Thank you. So I'm trying to think where to start. There was so much great information here in both of your slide decks, and of course, Commissioner Ross, with what you stated. I think if I were to go back to the beginning of this discussion, we talked about the Defense Suicide Prevention Office. I think, the Ames Research Center, we're kind of like them, but more local. It's like the GBI is a more local version of the FBI. And so we work statewide. The screenings Commissioner Ross talked about, we actually conducted them in 134 of Georgia's 159 counties, which is, if you haven't traveled around Georgia, oh my goodness, it's a lot. It's a very large state. So we were able to conduct these screenings. What's interesting, as we looked at it, so we used the screening battery assigned by the VA, which is a robust assessment. And so a few things I think are interesting. When we look at stigma, that was one thing that came up. We do see this a lot, especially with our transitioning veterans as they go into the community. And as many of you are likely aware, Georgia does rank near last in the provision of behavioral health services. And so we are constantly looking for, how do we better train our providers? To your point, how do we teach people to intervene in crisis? And so in the Ames Center, we have a clinical research team who's been focused on making handouts and very brief, light touch interventions that we can leave in offices, that we can leave in the field sites, we can leave in restaurants, essentially anywhere we think veterans or their families may frequent. And they have essentially basic tips to get ahead of suicide. So how do we better improve sleep? How do we educate on appropriate levels of alcohol use versus misuse? How do we educate individuals on lethal means safety, how trauma experiences impact our bodies in various ways? How do we teach people that it's okay to ask for help? And so that's part of what our clinical research team has been doing. And we have partnered with the Georgia National Guard, also with the Department of Public Health. And so one of the groups that we're also interested in reaching out to in terms of high-risk groups are our first responders. So across the state of Georgia, about 20% of our first responders are military veterans. And we're seeing the same issues and concerns when we think about suicide prevention in both our first responder groups, as well as in our National Guardsmen and women, as well as in our veterans. And so suicidal ideation tends to be underreported, partly the self-stigma, which we've discussed. I'm concerned I'll lose my security clearance, or red flag laws, I'll take my weapon, things like that. So what we're always interested in is, how do we reduce the things that lead up to that? So financial insecurity, food insecurity, mental well-being, factors such as that. The biggest issue that we've seen statewide, and by far and large, is social isolation. So our people say, I don't have someone to go to the movies with. If I had a flat tire, I don't know who to call. It's loneliness. And this is not just a Georgia problem, this is a national problem. And it's something that we've been working in year one of this project to identify where are the hotspots of concern in Georgia and how do we better direct resources to influence? For example, is financial insecurity a statewide problem? Maybe. What we've done is we've created maps to see where that problem is the most salient. And then where is food insecurity our problem? Where is loneliness our problem? And so as we move into year two of this project and other projects, we're looking to better direct resources to target community-specific problems, and that's through outreach and partnerships. I'll pause there. Thank you.
Okay, thank you, Dr. Moore. I'd like to turn it over to Rachel Holloman. So DBHDD also is a tremendous partner in everything we do and is a member of our Governor's Challenge team. So Rachel, why don't you talk about what all you're doing within the Department of Behavioral Health and Developmental Disabilities?
Dr. Moore, give me a good segue, because when we talk about, and I can talk about so many different levels, and I don't want to repeat anything that's been said, but when we talk about social isolation, one of the things that we do have in Georgia that I would be remiss if we did not talk about is our Georgia Crisis and Access Line. And our Georgia Crisis and Access Line is manned 24/7. Anyone can call 24 hours, 7 days a week to that Georgia Crisis and Access Line and have somebody on the other end of the phone in Georgia to talk with them. These are professionals that are trained. If you don't need professional help necessarily, maybe you're not in crisis, but you just need someone to talk to, they can directly connect you to our peer support lines, which is a peer-to-peer warm line. That person can stay on the phone with you. Georgia also has peer support centers that are open just to go and help reduce some of that loneliness. One of the biggest things that has happened in behavioral health and substance use disorders and suicide prevention in my lifetime is 988. And Georgia has, DBHCD in particular, has partnered with SAMHSA and is over the 988 crisis line. And I think we're pretty lucky in Georgia in that we already had the Georgia Crisis and Access Line. We already had a crisis continuum in place that helped us launch into 988 from a good foundation. And I will tell you that people are calling. We talked about rural mental health. Our rural areas in Georgia are definitely calling 988. Numbers and data and research shows us that that's where the highest call volume is coming from. And being from a rural area, that definitely makes me know that we're getting the word out and people are utilizing it and they know that they can call it. I'm going to echo what everybody said. One death in Georgia is too much. One death by suicide is too much. And so we want to do what we can do to help people stay connected. And 988 and GCAL, which you can also download apps, you can chat. That's something I always like to make sure people know. I do speak to a lot of teens and families, and I'm like, I don't know that anybody, a teen or a young adult, ever goes anywhere without this. None of us. I think all of us sitting up here, one, if not two, that we are hanging on to that where you can chat. Maybe you don't want to pick up the phone and call. Maybe you don't know what to say. Maybe it's a little bit too real for you at that moment to be on the other end of the phone, but you can text, you can chat, go through that app. You can find out what resources are available. Georgia also has a website through DBHCD that's 100% committed to prevent suicide. It's called preventsuicidega.org. It lists everything that we do in Georgia for suicide prevention for the Department of Behavioral Health. It lists our PSAs. One of our programs is Safe and Secure. A lot of what we're doing in the state of Georgia is what we're seeing in the national level, is what we're seeing with GDVS. We really want to limit access to lethal means.
Excuse me.
And so,
Rachel, I'm sorry. Pick up where you left off. In a few minutes, we have Congressman Bishop who's going to join us, and we're going to come right back to you. Congressman, sir, thank you for being here. And just for everybody, Congressman Bishop is a long-term representative from the state of Georgia. He is in southern Georgia. He actually represents priorly Fort Benning and Fort Moore. So long-term advocate for veterans and our military families here. And he's actually formerly on the House Veteran Affairs Committee. So with that, Congressman Bishop,
They have to join you into it. Now you don't have the other people join you. It's just him now.
Okay, go ahead. Start. They can hear you. Go.
Good morning. I'd like to thank the Georgia Department of Veteran Services for organizing today's forum, and I'd like to thank Mr. Sean Hanley of GreenVeterans for hosting. I apologize for being unable to attend in person today, but I'm honored to be able to be with you remotely as we tackle the challenges that we face in confronting suicide among our service members and our veterans. I'd like to recognize Parker Gordon Fox's parents and extend my deepest condolences. More than just a soldier, he was a son, a family member, a cherished friend, and a loved one to many. It's very important that we remember his humanity, as it's often too easy to simply see our military members and our veterans in the context of their service. Though they protect our country, who they are is just that important. This is important as the job that they do. While Parker Gordon Fox was a staff sergeant and a sniper instructor at Fort Benning, now Fort Moore, he was also a kind and generous soul who we lost all too soon. No corner of this country is untouched by the tragedy of suicide. Every community has experienced it. Suicide among our troops and veterans is alarmingly high. The data reveals that suicides have increased 44% between 2015 and 2020. Defense Secretary Lloyd Austin has taken significant measures, including the establishment of a commission to study this matter, leading to the implementation of its first set of recommendations. In Congress, we work diligently to ensure that our military families and our veterans have the resources they need to care for them while they protect our country, as well as when they take off the uniform. As co-chair of the bipartisan Congressional Military Family Caucus, I know that an individual's military service affects not only them, but their entire family. And conversely, their family's well-being affects our military services. Each year, I co-host a summit with my Republican colleague and caucus co-chair, Congresswoman Kathy McMarsh Rogers of Washington State. The event provides a forum for our military families to directly engage representatives of the federal departments and agencies that serve them, as well as military and veteran service organizations. We highlight and discuss military family and veteran resources, as well as discuss their efficacy and how we can improve them. This includes resources to support mental health as well as suicide prevention. All that, of course, is built on the work we do in Congress to create, fund, and improve the departments, agencies, and programs that encompass America's armed forces and our veterans community. This year, I introduced H.R. 3811, the Veterans Mental and Behavioral Health Quality Care Act. I introduced that alongside my Republican colleague, Congressman Pat Fallon of Texas. The goal of this bill is to guarantee that veterans get top-tier care by having comparable service both inside and outside the VA system. Also, as a senior member of the House Appropriations Committee, I work with my colleagues every year to ensure that these programs are robustly funded and well-run. This includes the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. Many of you are likely familiar with this program, which provides resources for community-based suicide prevention efforts that help our veterans through outreach, prevention services, and facilitating connections to VA and community resources. In fighting to prevent suicide, there are many challenges to overcome, from stigma and trauma to having access to resources and trained professionals to help. Communities across the country, from New York to California, Georgia to Alaska, as well as our women, Native American, and minority community organizations, have used the Staff Sergeant Fox Suicide Prevention Grant Program to ensure that veterans, no matter where they are or in which community they live, can be reached. More broadly, as the previous Congress came to a close, we approved a funding bill that robustly supported our service members' well-being. With the Department of Defense, full funding was granted for suicide prevention and sexual assault programs, including a notable $479 million for the recommendations of the Independent Review Commission on Sexual Assault. Additionally, for the Department of Veterans Affairs, a massive investment of $13.9 billion was made in mental health care, ensuring that services like the Veterans Crisis Line, which is witnessing an unprecedented surge in demand, can be adequately maintained. And we want to make sure these programs work. For example, Congress has mandated a comprehensive study, a study on its effectiveness, focusing on the number of veterans contacting the hotline, subsequent follow-up services, and the tragic instances where some veterans, unfortunately, did not get the help that they needed in time. Congress introduced an expansion of mental health training for the Department of Veterans Affairs, promising an additional 250 paid trainee slots in vital mental health disciplines. The Defense Department is in the process of implementing the Brandon Act, which was passed by Congress and signed into law by President Biden as part of the National Defense Authorization Act of 2022. The bill was named after Navy Petty Officer Third Class Brandon Caserta, who tragically died by suicide. The Pentagon has issued guidelines to ensure that service members can seek mental health evaluations confidentially and promptly. Congress has called for detailed evaluations and reports from the Government Accountability Office on various aspects of mental health services and suicide prevention training programs. The Suicide Prevention and Response Independent Review Committee has also put forth recommendations underlining the need for reforms in the military promotion system and comprehensive reviews on unpaid and delayed payments to service members. I'll continue to work hard in Congress with folks like my friend and colleague, Congressman Austin Scott, who is also participating in today's forum, to help meet this challenge and support programs like the Staff Sergeant Fox Suicide Prevention Grant Program, as well as health care, mental health care, and other quality of life programs that are vital to our military families and our veterans. While we cannot bring back the lives of the loved ones we lost to suicide, their legacy, like that of Staff Sergeant Fox, will drive us to do better in recognizing and meeting the needs of and reducing the risk of suicide among all of our families and our veterans. Thank you again for organizing today's forum and for allowing me to join you in this very, very important discussion.
Have you hold off for just a second because I wanted to just touch. Congressman Austin Scott said, and a very brief conversation I had this morning with Dr. Sundarama, and that is the nonpartisan nature of this issue. We are living in such a divided country, and when I was talking to the Foxes, one of the first times I spoke with them, we lost Parker in July of 2020. This grant's already gone through the cycle twice. So certainly when Washington wants to get to work, they can do it. We've seen them move quickly on things like this. But Dr. Burnett and Dr. Sundarama, I'm sure you've both either testified at hearings or you probably will soon enough. Can you kind of give us your input on maybe the optimistic part of the nonpartisan side that we see, and just kind of dive into that ugly political word and just give us your thoughts on it.
Okay, sure. No, I agree. We've been very fortunate that, much as, suicide's such a tragic issue, at least the response is not caught in any political fray, and it's a very nonpartisan issue. And it's always been that. I mean, even back, if we look at when, there was very little being done for suicide prevention across the country. If we had back in 2002, I believe, or 2001, when we had a senator from Oregon State, a Republican senator, and he lost his son Garrett, and so the Garrett Lee Smith grants were named after his son, and that was really the first influx of money that came into suicide prevention federally and nationally. Similarly, there have been other Democrat Democrat senators and members of Parliament of the House who have always pushed forth legislation and support for suicide prevention. When we do get calls from either from the committees or from any of the representatives or senators, it's bipartisan. I mean, everyone wants to know what's the data, how is the data changing, what is the department doing to address this issue, and there's really very little other other motive other than just trying to prevent suicide.
Yeah, I don't need to reach very far back. So I was in DC 2 weeks ago at a congressional roundtable talking just about these grants in the future forward for these things. It was represented by both sides of the aisle, and there was no discrepancy about everyone's support for this. The conversation was, how do we make it better and how do we make it broader? Where do we go next for this? And that's the only conversation we've had from everybody. As I said, this is I understand it gets banted around in political circles, but it is personal on both sides of the aisle as well. So the support is pretty uniform from our experience.
Great, thank you. And one moderately related. I'm just curious, and this is for DOD and VA. Suicide prevention has obviously become, thankfully, a forefront issue and a clinical issue now, as it hasn't maybe been years ago or seen that way. Are you working with other countries? Are there other countries involved? Where are we compared to them? And do they see this as much of a problem, their country, than we do here?
So I'm going to set her up for this because Ramya. So just last week, or was it this week, that we were in Slovenia, DOD, VA, SAMHSA. I routinely talk to other countries, as does Ramya and her team. So while I was working with Israel and other countries who have seen a significant drop, and the reasons why that is. So yes, we do have ongoing dialogues with other countries. Do you want to talk about Slovenia?
Sure. So we actually, this was a joint, there were actually 3 sessions that the DOD, VA, SAMHSA, and CDC presented at the International Association of Suicide Prevention Conference in Slovenia. And there were representatives from literally every country I can name there. And the problem in other, I mean, it's different. The problems with the method is different in the U.S. because of the prevalence of firearms. Our method of death seems to be more firearms. In many other countries, it's more either poisonings or hangings. So the method tends to be different, and hence the prevention strategy tends to be different. In terms of where we are in terms of overall I would say we are actually doing pretty well. Most countries do not even have a national strategy for suicide prevention. And the fact that we have 988, that is not a national crisis line, is not something most countries have. And I'm not talking about I'm talking about Western Europe. I'm talking about countries that we would think that, Australia, the UK, countries where you would expect that they would have similar systems to us, but we're actually, I would say, way farther ahead. And I also think that interagency collaboration that we have and the close working relationship we have across not just the 4 agencies that I mentioned, but also with Department of Education, even agriculture. I mean, a lot of the other federal agencies and state agencies that are participating in this suicide prevention movement, that national focus, that national push, is not something that other countries have seen. And the feedback we got in our sessions was that, was it our national strategy pushing it? What was it that was pushing it? And I would say, I don't know what's pushing it, what makes us different from, what makes us be able to do that more effectively. But certainly I think just the committed passion of the movement and all the people, all the leaders in our field have certainly helped that. And that's a huge, that I think,
Great.
yeah, it's very rewarding for me to actually when I interact with other countries.
Well, thank you. And just to let everybody know what timetable we're on here, so you have an idea on where we're going. We're going to go back to Rachel. We're going to talk a little bit about the localized issues with the Staff Sergeant Fox grant, and then we'll all have probably a few more comments, and we'll probably wrap up a little early. And there's a place for food downstairs. But so we're going to go ahead and drive through another 20 minutes or so, and then probably conclude a little early. Before we get to Rachel, again, one more thing I wanted to bring up, an issue that has come up a lot of times that I hear about. This will set back on our DOD and VA SMEs. We hear a lot, and Rachel touched on it, about the suicide hotlines and so forth. I've seen, whether it's articles or otherwise, the push to find these at-risk people before they even consider finding a suicide hotline. So what is being done so we can get to them before they even get that far? Because at that point, it could be too late as well. Well, specifically, and data, right? You got a lot of data with a lot of these people, especially from DOD, transitioning to VA. Do we keep an eye on at-risk people before that time comes? And I'm just kind of trying to figure out how we get more ahead of it.
Yeah,
We do. That's a big question because there's lots of pieces to that. I guess the simple answer and what we most want to be sure is clear in hearing a response to that is absolutely. So VA system, DOD has what's called the DODSER system, where they track people who are known to be at high risk before they release out of service. And we can now see those individuals and try and help do outreach and engagement for those veterans. But it certainly doesn't stop there. So to answer your question, do we see and what are we doing to try and engage? There are a lot of lanes of effort there. Some of them are owned by VA, but we know that can't be the sole answer for this, right? There are going to be veterans who choose not to go to VA or want to be engaged by the VA. And so that's where we are trying to amplify partnerships with you all, because it's got to be 1,000 points of light, 1,000 points of service, that there is no wrong door that a veteran can go through to get help. And that's ultimately what we're wanting to get to.
All right. Okay.
and the only thing I would add is also the importance of families, educating families, and having, if nobody else knows if there's something else going on, the spouse does. And so how does the spouse then help that service member with their issues?
Sure.
And then also looking at more broadly all the risk factors we're talking about. If there are relationship issues, if there are financial issues, if there are substance use issues, how do we get help at that for those issues such that we don't get to the point of suicide at all? So that's kind of a large part of what we do in terms of partnerships within DoD, working with offices that are addressing these other risk factors for suicide, and not really bringing necessarily even the suicide conversation there, but providing them support to address those concerns such that the risk factors are addressed and the protective factors are enhanced. The other part is building up resiliency and building up the ability for especially the younger service members to be able to cope with life stressors as they go forward. So that's not suicide prevention, quote unquote, but it does help them deal with life stressors and hopefully not get to the point of thinking about suicide. So those are some.
Great, thank you. Rachel, if you could pick up where you left off, and Commissioner Ross and Dr. Moore, more on the local issue.
Well, and I think we're probably, I'll just real quickly close in this, is that if you don't take anything else away from here, we've all talked about reducing the stigma. We've all talked about the importance of talking about it, of it being everyday conversation, of suicide not being scary. Suicide prevention not being scary, it not being a word that we're scared to say or scared to talk about. Because the thing is, with suicide prevention, if you will ask the question, and if you will sit there and just listen and just show somebody that you truly care, you don't have to have the answers. There's professionals up here. There's professionals on all these resources listed. That's what 988 for. That's what the Georgia Crisis and Access Line is for. But if you can just show that person that you care, that can be enough to change the trajectory of that life. And there's so many other things that you can do, but that is something that you can do walking out of this room today. How often do we walk by somebody and say, hey, how are you doing? And we've already walked like 10 steps away before they could even say, I was having a bad day, but yeah, appreciate that. Like, you know, I mean, but truly showing that we genuinely care as a society. One thing that COVID did to us is it isolated all of us. And as we come back together, as we try to connect back together, just showing that we care for you as a human. That we care what you're going through, that we're there to listen. We may not have all the answers. And I think that's where a lot of people get scared in suicide prevention because they think they have to have the answers. And we're not asking you to have the answers. We're just asking you to ask the questions. We're just asking you to care about the human being sitting beside with you and just show that to them. And on that note, I just, DBHDD is here to support GDVS. We're here to make sure that our veterans and our servicemen and women and their families are getting the services that they need. There is no wrong door. We want to make sure that we get you help, regardless of who you get that help from. And so we're here to partner and to be a support for y'all. And I'll stop.
Great, thank you so much. Commissioner, do you have any?
Sure. I just want to thank Rachel for that. They are tremendous partners. I've personally called GCAL on a veteran that got to my office and was undergoing crisis, and they responded. And so it is at the local level, it is at the individual level, we make a difference. That's what I'd like to leave all of you with. And I'd also be remiss if I didn't highlight, I know Dr. Burnett had this on his slides and we got cut out for Congressman Scott, so he probably was going to cover this, but our women veterans. So Georgia has the largest growing population of women veterans across the nation, right? Yeah, many of us are here. We are more likely than male veterans to commit suicide, and our lethal means is increasing. There was a staggering statistic on his slide because we in the military were comfortable with firearms. And as he said, you know, the likelihood of surviving a gunshot is 5-10%, depending on the research. And that is how our women veterans are dying. And so that's a big issue for us here in the state of Georgia because of our population, is making sure we're reaching out to our marginalized veterans, not just our women veterans, but our LGBTQ plus veterans who may be at even a higher risk. So again, I'll turn this over to Dr. Moore again, a tremendous partner in this, but it is at the local and individual level we make a difference. And I just want to thank all of you out here because so many of you are already partnered with us in this for saving. You know, we save one, we've saved one. You know, one suicide is too many. I know Dr. Burnett already said that. That is our belief as well. But if we save one person, just think of the impact you've had. So Dr. Moore, over to you.
Thank you. So, I'll give GCal a shout out as well. So I had lunch with a veteran recently, mostly just sort of a touch point, checking in on him. We had lunch, we sat down. I said, "How are you?" And he just broke down. I'd never seen this happen before. I've known him for some time. And I said, "What's going on?" And he said on the way over, he had a panic attack on the interstate. So much traffic. And I said, "Why didn't you call me?" And he called GCal. And he said, "I'm not in crisis. I'm not going to harm myself." And they said, "Well, what do you need?" And they stayed on the line with him. And that was one person, right? That made a huge difference for them. So when we're doing our work, we look at multiple levels. So we look at the individual level, we look at teams and leaders and organizational policies, and how each of those sort of dynamically interact to influence outcomes. And the outcomes that we're most interested in are healthy communities and safer communities for individuals. And so if we think about what is the DoD doing, it's not a prevention standpoint as well from a mental health or behavioral health side. They're also doing things like advancing science on musculoskeletal injury reduction, which we know veterans report high rates of chronic pain, and chronic pain can seem to make things worse. It can drive them to want to consume alcohol in excessive amounts, and they get to that 2 minutes where time and space is required. And so from a prevention standpoint, it's not just VA's job, it's also DoD's job. But before that, it's our job as a community to build these safe communities and the resources available, and to train healthy, resilient young individuals to join the military and then come back into society and continue to contribute. And so we're looking at this from multiple angles with our Georgia National Guard partners, the Georgia Department of Veterans Service, and then with nearly 4 dozen different police and fire agencies that we work with directly as they go out into the community to engage with others. Thanks.
Great. Thank you, Doctor. Just about on time. So look, I want to thank everybody for being here, especially Dr. Burnett, Dr. Sundarama, for making the trip down here and missing your girl's 13th birthday. It shows your commitment, but both of your levels of commitment. And I want to thank certainly the Foxes for coming down here. You heard Commissioner Ross talk about, the 5 somewhat confirmed moments. Yeah. You got your son partially to thank for that. This is titled an inaugural event for a reason. This is not the end. This is the beginning of a fight we got to keep moving forward with. So the Fox have generously said, let's do this again next year. And I think we're going to be ready to go over the next year. I'm sure new programs will move forward. Mission Daybreak, brilliant ideas, will work. DoD will continue moving forward. The leadership we have will continue to get more experienced and better at their jobs. And thanks, Commissioner, and your team. And thank you, everybody. Thank you, everybody. I am going to ask our photographer if she can come up here, because we got a couple of presentations for Dr. Burnett and Dr. Sundarama. They don't have your names on them because we have some surrogate work happening, so you might have to drop those off. If these are too big for you, we'll package them up and send them to you. So did any of you all have last thoughts, or are we all set?
No, just very thankful to be here, and thank you for pulling this together.
Okay, thank you. And I don't think I told y'all, we were live streaming on 2 platforms, so it's a lot more than just here. I guess I should have told you that before, right?
My comments would be, I am humbled and grateful to you all for what you do. What I heard in your questions is essentially what I imagine most all of you want to hear, and what I want to hear as just a normal citizen and a brother. Are we doing everything we possibly can, going through any door into any area, no matter where it is, to save a veteran life? And that answer is yes. There's a lot I couldn't cover, so I hope you'll give me an opportunity to do that with you during a break. But her comments, I think, struck the right tone, which is it does not take a specialist to be a hero in someone's life. You just got to care and be willing to step forward and know in that moment where to connect to others' resources. So thank you for the opportunity. Thank you all for what you all do and let me be a part of that. And if you do it next year, we'll be here again. So thank you.
Great. Thank you, Doctor. Appreciate it. We have we'll take a couple quick questions. Go ahead. Okay.
We were founded almost 3 years ago. My team is made up of veterans. I have a Vietnam veteran who also served in Iraq. And I believe that each one of you up there sitting today does truly have a passion to go in this situation. You did touch on a couple of things that is something that I actually came here today to go, this needs to be done. But there are things I think that you're saying these things are changing, but our veterans are not seeing them change. Within the VA system, the wait is the same with their medical, and that in itself causes anxiety. My husband has been waiting 4 years, 4 years to get a back surgery for something that was supposed to be taken care of while he was in service. Okay, and that's just because he just started the process 4 years ago because he's like, he put it off for so long because he's like, nobody's listening to me. His mental health care professionals, he has a new one every 3 to 6 months. How is he supposed to build trust with them when they're ever changing? So with us serving the largest area of Georgia of military veterans, we have everybody, every branch. And they're all suffering. I had sat down with them before I even created this organization, 6 months straight. I talked to thousands of veterans. Thousands. Every single one of them had the same thing to say. The VA is an issue, okay? And community is definitely, I'm glad you touched on that. Community is a huge thing. No one listens to me, and the ones that do brush me off. You know, that there's no, also, you guys talked about the transitioning out of the military, I believe it was in Europe. I know some of it has changed, but yeah, they offer these, but it's go to this table, go to that table, go to that table, go to that table, go to that, and they're forgotten. They don't know what to expect. Their entire lives were decided for all choices, what they're going to wear, when they can go eat, when they're going to exercise, when they employ, you know, all of those things were decided for them. And now some of them, you know, my husband served 12 years and 3 tours to Iraq. All 3 of them, he was non-employable, and he went anyway without her. This is on his service country. And his country failed him. Okay, I'm sorry, I'm standing here today for him and for everybody else that I have helped. We are a very small grassroots organization, but we are growing and we are doing what we can to do our community. But it's hard when there are so many organizations that are out there talking and nobody's doing.
We've got people we can touch base on that. We connect you with some people that can probably help your husband. We're going to go ahead and move forward on this. I'm grateful you're here.
So
Wait, excuse me one second. Please let us kind of finish up here. I promise you, I will connect you directly. Whoever you need to talk to at the VA, I'll figure it out. Talk to me after. But I'll connect you with somebody. But we want to kind of keep moving because everybody has a story. Some of them is not good stories, and we have to hear them. Some of them are positive, and this is not an effort to do anything. Let's kind of move forward. I give you my word. I'll connect you with who you got to get connected with. Okay, but we're gonna move on from here. One more quick comment, Mister.
Thank you for being here and all the work from the Wing Corps Hot machine. I will tell you this follow a lot of your numbers. Appreciate it. However, I do believe there is a disconnect. The problem with veterans starts with the Department of Defense. The Department of Defense created the veteran. The Department of Defense creates them, sends the veteran to combat, brings the veteran back, and then sends the veteran into the community. The Department of Defense does not do enough while military members. They do, you did talk about the transition program. It's very it is like, hey, take some notes, having you know set up that. I feel like if you can take a message to what the Department of Defense has to have a transition program that is more robust because they're the ones that are leading the veterans that commit suicide into the site. They lead it to the Department of Veterans and they can lead it to everybody else, but they're not doing their part. So I'm training for language. From the GDVS, I was trained to seek and destroy my enemy or defend our assets. That is my mindset when you're in combat. Sure. I know how to hold it. I know how to tell people that you never game. And I know how to execute a daily life. Having said that, the people that are committing suicide, mostly or combat infantry veterans, and have been in these scenarios, and it becomes very easy for them because of what I just said. So if you program a military person to do these things, you have to deprogram while they're still in the service. You will not change the system. And I'm not trying to know your efforts. I'm not. They're great leaders who work hard, God said, late night. But it's not going to change because the system that's feeding suicidal veterans is not doing anything to deprogram them while they're still in the system as active duty members. There should be like a pre-run program. Maybe not. But before I get out, I'm going to start wearing civilian clothes. I'm going to go into a certain whatever. And I'm going to work within that system. I'm going to be amongst my peers, but I'm going to slowly ease my way. The people that are going to be helping me are going to tell me, what kind of job are you making? What kind of income are you going to make? Because somebody mentioned something about economic hardship, and I think you did, and you said, is it a fact? Absolutely, it's a fact. It is absolutely a fact. See, economic, all those are factors. Or you're going to get a job. If you try to get a machine gunner, which I almost did, right? Family members of me. But another thing is, there are 92 synonyms for related mental health, so we can't change the stigma. The stigma is placed wholeheartedly by the people that are creating a military crisis, suicide hotline. He made it more fun. His Fox made it if you could have seen my son, he was a warrior in Achilles, muddy and dirty. He's exactly right. A warrior. So everybody on the mirror lets at 33,000 feet. Veterans coming out of the Department of Veterans or coming out of DOD or flying below the radar, there's a huge disconnect. You can say, oh, this is here at 33,000 feet, but it is not connecting below the radar. The reason it's not connecting below the radar is because you don't have common veterans that you're working with on a daily basis. You're not speaking our language. And I'm a combat veteran, great. I'm a ground company. I'm not an educated at all. Not clinics. I'm a ground company. We're speaking two different languages. There's totally disconnected. Two different languages. You can get a group of contractors together and a group of developers together that can have conversations with, and you'll get somewhere. They'll get somewhere. Here, we're not getting any. We have a disconnect and we're losing veterans getting some prices.
See,
And it's been rich.
let's kind of move forward. Nobody's there's always going to be a gap,
Yeah.
you know, and the effort to come down here and talk to all the grassroots folks is an effort to close the gap. Ideas like Mission Daybreak. Have you ever heard of anything like that? You have a government agency saying we don't have all the answers. Help us. And they get flooded with 1,300 different ideas and thoughts to move forward. So I commend it's nothing perfect. We're talking about government, but give me a minute. Let's move on so I can get to somebody else and we can move on. But to your point, it's well taken. It's
So nothing too soon. Let's go. One of it, prosperity. Another one, happiness health. The third one, welfare. Much better than suicide prevention license hop. 92 synonyms that we could use to change the state of the verb motion. It's very important. So that people feel like they can go there and not be ashamed or feel like they're no longer a hero or and no longer they no longer kind you say that this is from a combat veteran's perspective. This is what I see or moves along. Thank you very much.
Thanks, Steve. Let's do one more. That lady had her hands up for a while. Let's do one more. All right.
Painting in here, with the legal officers.
I'm with you. Thank you for that. And I just to touch on that and close on that. That was one of the first things I brought up. And Doctor, you brought it up nicely. The transition, it is a challenge. So I'm glad you brought it up. I'm glad you brought it up, Steve. And that's always been an issue. As I said, you know, when I got out of the Marines, as I said, I had a plan. But a lot of people don't. They get that discharge. They go from being in the military with 3 hots and a cot, all the health care they need, and the very next day, none of that's guaranteed anymore. So I'm with you there. I'm glad you brought it up. I'm glad DOD is addressing it. And do they have to do a better job? Probably. That's why we're here. So I want to thank everybody. We're doing this again next year. I want to thank the entire panel for being here. And I want to thank our congressman who can't hear us anymore. And thank all of you. There's a little bit of light food downstairs. I'm not sure of the room, but somebody will share that with you. So thank you, everybody. We'll see you again. Thank you. Good. Thank you. That's great.
This one here is
Right.
you and we have 6 months since we started our veterans research.
Yeah, hang on one second.
So we have a community-based team mission.
and stand their own guns and they're deciding about not Spain. So it's
Well, and let me say something real quick to that, then I'm going to legitimately close. But for Dr. Burnett, real quick, you know, when the first grant was awarded to the state of Georgia, I immediately called Trish up and I said, I need you to talk to the Fulton County group, help them get their grant information together. When we saw the grants re-released, it mainly, correct me if I'm wrong, mainly went to the grant, the awardees from the year prior, with a few others. So how big is the budget going to be on this? Because, you know, to y'all's point, you know, I plan to make this almost a campaign. So you're going to get a lot of applications from Georgia going forward. You got 159 counties, like Dr. Moore said. I'm not saying you're going to get 159 applicants, but we certainly are going to pick up the pace here in Georgia, probably other states. So how do you see that? And I promise we're going to close on that, but because this is a Parker Fox issue and really getting the money down to the locals, how do you see that grant working in the coming years?
That's actually why we were in DC, is to, so the FY26 presidential budget appropriation is being requested now. And so we are starting to make a request to scale this much bigger.
Great.
If you are familiar with SSVF, which are homeless grant and per diem grants, we're going to follow, our recommendations are going to be similar to that. We're going to want to scale this until we can get it out everywhere it needs to be.
Great. Thank you. So keep applying. Tell the neighboring counties to apply because there's an overlap here. The state of Georgia gets one to help as many across the state as possible, but the counties can get them too, to reach out more people, more local, and more local. So I would advise you to, you know, this is a campaign. It starts at Commissioner Ross's office. So just call Commissioner. We're going to connect you. That's a perfect exit there. So thank you, everybody. Let me say that again. Oh, good. We'll push them to apply next year. Fantastic. All right. Thank you, everybody. I appreciate y'all. Thank you.
We're gonna do a little award ceremony here.